Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of prostate cancer. Dr. Travis Brown, I believe we have touched the prostate once before, but we're coming back to it afresh with this episode.
So the previous episode was prostate cancer looking at PSA. So this is the screening test, which is a challenging topic as to, advice and, different guidelines around the world. The first part I want to actually say for this episode is thanks to Professor Fiona Maclean. So she's helped us pull this episode together, and I think it's a fantastic episode. Really helps clarify exactly where we are with understanding prostate cancer. And so, yes, we've discussed PSA. Now we're looking at prostate cancer itself. And this was, in the historical context, the first medical documented case we've spoken about. This was in 1817 by Dr. George Langstaff, and he didn't actually know what it was. He was actually looking at it, and he wrote it in a case called fungus hematodes in the urinary bladder when he was doing an autopsy, and he saw this tumour coming out of the bladder and extending everywhere. And so we discussed this in the previous episode, and this was episode 48. This was looking at PSA. Absolutely relevant here, worth listening to again to get yourself up to speed in PSA and what the recommendations are for that. So it wasn't until the early 20th century that we started to understand prostate cancer. We started to learn. The challenge for prostate cancer, particularly in its infancy when we're understanding it, is how do we grade this? How do we explain this to other people who, what this prostate cancer is? The traditional way of saying something cancer, we look at differentiation, well differentiated, moderate, poorly differentiated, but there was a number of different systems in the early 20th century about how to do this, but there was no consistency and standardization of this. So this was a urology problem. And
that measurement would have all been happening post-mortem, wouldn't it?
Well, this would have been a challenging trying to get the prostate out, how you actually detect prostate as well. So people would have presented very late anyway, because there was no way to detect it. PSA was 60s, 70s when it was initially identified. And so this was actually a problem. It was actually a problem that was in the 1960s. It was the Chief of Urology from Minneapolis Veterans Administrative Hospital had a problem. And his problem was he needed to communicate the results of prostate cancer to a multidisciplinary research team that was happening at the time. And he needed to say, how do we communicate what this prostate cancer is? And he approached Dr. Donald Gleason. Now, Donald was born in 1920s. He was born in Iowa, USA, and he studied at the University of Minnesota medicine. Now, he did a PhD in physiology. He did his residency at Minneapolis VA Hospital. He studied 6 months in Paris, and he eventually came back and became the Chief of Pathology at Minneapolis VA Hospital.
One of your heroes.
Well, he is. And in prostate cancer, it's one of those things that the Chief of Urologist came up and said to him, challenge, how do we standardize, or how can we communicate effectively prostate cancer to other people in this research team? This challenge forced him to reconsider the approach to prostate cancer, and he noted,
need to identify different histological pictures which could be recognised repeatedly and taught to others.
The traditional approach was looking at it in grades. This can be, and they initially started thinking of very well differentiated, moderately, poorly. Ended up studying 270 patients in the hospital who had had prostate cancer, and noted that there was actually more than one class that was going on. And his approach was quite innovative. Instead of going just the worst grade, which is how we traditionally look at cancers, he started going, well, what happens if we combine the different grades? And this is when he ended up doing a drawing, and he drew 9 pictures initially of these cells and glands that eventually he put into 5 patterns. And these patterns, he then started to say, well, this is a grade 3, this is a grade 4, this is a grade 5. It was simple, it's easy to follow, and most importantly, reproducible. And so if you see these grades, you can say, well, what are the 2 most predominant grades? And this is when, now, it ended up turning out that grade 1 and 2 is pretty much normal, but so we consider cancer in the grades 3, 4, and 5. And so what you're looking at when we're looking at prostate cancer is we talk about the top 2 grades. And so this is often when you'll hear prostate cancer referred to as 3+3 or 3+4 or and so on. And so later on, it was found that these grades actually reflect the patient mortality rate. So there was the worse grade, the worse prognosis for the patient, unfortunately. And so
did he know that at the time?
No. So this was the thing. He was just trying to communicate how to explain, but it correlated well with the outcomes of the patient. And so this was actually, he ended up publishing this in 1966. Now, nothing happens in medicine fast, unfortunately. So it was 21 years later that this was universally adopted at the recommendation of urologists. And so there have been refinements over the years. There has been things, adjustments like cribiform patterns have been introduced into a certain grade. But this is the whole thing of the amazing story. This was, if a surgeon from Spain now talks to a pathologist in New York about a patient, just saying it's prostate cancer Gleason 3+4, they know exactly what they're talking about. And I think that's the power of pathology, that you sit there and just go, that's incredible. That universal system we use now is just an amazing tool to be able to explain what is happening with the patient. And so this is where prostate cancer comes in, and this is where we will discuss with our guests, because prostate cancer can have the full spectrum of incredibly aggressive, needs to come out straight away, or indolent or behaving indolent way, and we'll keep an eye on things. And that's sort of a bit of an unusual feel that someone says, oh, I have cancer, we're just going to keep an eye on it. But
that's where you hear that thing about it's a disease where people often die with it rather than from it.
Right. And so this is the challenge where we find ourselves. And what we know now is that prostate cancer is rising. Is that because we're detecting it better, or is that because the actual incidence is genuinely increasing? And so this is where we find ourselves today, and something that we want to discuss with our guests to understand that how are we managing, how is prostate cancer going, and how does the patient actually approach it?
Professor Fiona Maclean is a clinical professor in the Department of Clinical Medicine, Faculty of Medicine and Health Sciences, Macquarie University. She's authored more than 100 peer-reviewed papers, as well as 2 chapters of Sternberg's Diagnostic Surgical Pathology and 1 chapter of Histology for Pathologists. Professor Maclean is a past president of the Australasian Division of the International Academy of Pathology, and she has interests in urogenital and musculoskeletal pathology. She also works with artificial intelligence, partnering with Franklin AI to develop tools to assist pathologists. Fiona's our guest on This Medical Life podcast. Fiona, welcome.
Well, thank you for having me. I'm delighted to be here.
Fiona, how common is prostate cancer?
Well, I think the short answer is very common. In Australia, for the first instance, it's the most commonly diagnosed malignancy in men. And each day in Australia, 72 men will actually be diagnosed with prostate cancer. And so that means 1 in 5 men are actually diagnosed in their lifetime. And 1 in 23, sadly, in Australia will actually die of prostate cancer. And it's the second most common cause of death for men relating to cancer in this country, and that's about 10 a day. But if we think about more globally, it's actually the most common cancer in men in 112 countries and accounts for about 15% of cancers. And there's a great paper that was released last year. There was commissioned by the Lancet looking into prostate cancer worldwide. And there were 1.4 million cases diagnosed in 2020 of prostate cancer worldwide. But due to changing circumstances in low-income nations, it looks like this will rapidly increase with men's life expectancies getting greater and longer. We're expecting about 2.9 million cancers by 2040 globally. So it's going to be a huge burden worldwide.
Those statistics you just gave me, does this put paid to the myth that most men die with prostate cancer, not because of it?
No, because it is very common. And so there's a very high percentage of men that have an indolent type of prostate cancer that we will diagnose. So it's actually a really unusual cancer. So in the sense that, say you had a breast cancer, you would have that dealt with straight away. So we would either give you radiotherapy or we'd take it out. We'd do something about it, right? With men with prostate cancer, we know that disease is quite different, and you can have an indolent form which does not progress and does not metastasize and will not actually lead to death. So it's actually really important not to overtreat those men. So those men, we need to actually be able to say, well, which category are you in? We don't want you having the excess treatment, which has an anesthetic involved. It has side effects such as impotence and incontinence. These sorts of effects that we might have from actually treating, whether we treat surgically or with radiotherapy, those side effects are still there. We don't want to have a man have more risk of the side effect than actually the treatment for the disease. And so we do know that the vast majority, probably about 80% of prostate cancers are indolent in nature and actually don't progress. So in those men, it's good to know they've got it. They probably are somebody who's making a bit of cancer, so it's a good idea to keep an eye on them, and we want to put them on what we call active surveillance, where we can actually get them back again and we can give more assessment over a later period of time. So we'll get them back in, say, 18 months or something, and have another round of testing, just to see, okay, is this the man with the indolent cancer that's not going to progress at all and we'll just keep watching him? Or is he the man that's actually going to progress and we're going to have to do something about him?
How useful is Gleason grading?
It's funny, I remember when I started medicine, my first lecture on my first day, the professor of medicine says, we're going to teach you so much stuff. You're going to have to be like a sponge. You're going to have to learn all this information. But 1/3 of the stuff we teach you is actually wrong. But we don't know what third that is. So, I mean, this was a good while ago now because I'm not young. But I thought it was a very interesting thing to think about, and how we change the way we assess things over time. In effect, the Gleason system's been around since the 60s, and it's actually a really strong predictor. It's the most powerful prognostic factor in prostate cancer. Now, people sort of still refer to it as the Gleason score, and in essence, it really still is the same Gleason score, but we've changed it a bit. So there were big modifications made in 2005 and 2014, and we still refer to it as the Gleason score or the modified Gleason score. So it's still essentially the same thing, but it has evolved to adapt to our changes. So we now have a phase of screening. Back in the 60s, we didn't do PSA screening. We now screen. So in this country, at least, the majority of patients we see are actually at early stage and, have that more indolent looking cancer. So the more lower grade looking cancer, and we have to work out whether it's actually going to be the cancer that progresses or not. We've changed the size of the needles that we do for biopsies. We've got more information now because we have preoperative radiotherapy, preoperative imaging, which is actually really helpful in regards to the PIRAD score that we get from the MRI. So all of those things taken together, actually bolster the Gleason score, but the Gleason score itself is the most powerful prognostic factor.
We mainly use grade 3, 4 and 5 for Gleason. How common are those sort of categories?
So that was one of the big changes that I was just alluding to. So in 2005, when Gleason scoring went through a big review, we actually decided that probably Gleason's pattern 1 and 2, weren't actually significant, and they may have been recognizing tumor that was not really even proper tumor. It maybe was adenosis or something like that. And even on a core biopsy, because it's so narrow, it's actually really hard to see. I occasionally diagnose pattern, Gleason pattern 2, for example, on a TERP or a radical when I can see the whole tumor deposit, but on a core biopsy, it's too narrow and you can't say that. So you're right, we never diagnose 1 and 2 on biopsies, and so that's why the scoring starts at 3. It sounds a bit silly, we give 3, 4, and 5, and we don't do 1 and 2, but that's because we've gained extra knowledge. So, as I was alluding to, over time as doctors, we learn more things and we learn what's useful and what's not useful. So the most common pattern we do see is Gleason pattern 3, by far and away. But, with the patterns, we actually make a score out of them. So we're actually giving 2 patterns together to give the final score. That actually takes into consideration if you have some higher grade tumor, which is going to drive that patient. It's going to be the thing that, determines if that man's going to do worse in regards to prognosis. So the fact that the score is made up of 2 numbers is actually really helpful, because you can pick up those smaller foci of patterns 4 or 5, which are really important information for the clinicians in determining whether this man goes on active surveillance or whether you treat him here and now.
When we're looking at biopsies and excision specimens, how accurate are the biopsy to the excision?
Yeah, that's a really good question, because if you think about your prostate, mostly men's prostate's about the size of a walnut, say, and as you get older, it's like I always say to people, it's like death and taxes. How Mark Twain talks about them being inevitabilities in life. Well, unfortunately for men, the other inevitability in life is their prostate getting larger, and for some men, that'll cause some obstructive symptoms, and you probably heard of benign prostatic hypertrophy, or BPH. That's related to the prostate getting larger. So when we actually think about us doing biopsies, and if we take 12 sites of biopsies, in most men, that's only a 1 or 2% sampling of the prostate, right? Before the time of MRI with the PIRADS, determinations, we used to just do, sequential biopsies from all sites, all quadrants or parts of the prostate. But you're only sampling a small area, right? Nowadays, because we have the guided biopsies, that are guided by the MRI finding, that actually helps us to target the areas a lot better. So without having the MRI, it's less accurate, but it's still very good. But with the MRI as well, plus the biopsies of those sites, and in Australia, we tend to also do the background just to make sure there's nothing there that we haven't missed. The accuracy is actually very high, because of the fact that the other thing that prostate cancer is a little bit different with compared to other cancers is it's very multifocal and it's very heterogeneous. So most men, when I look at a radical prostatectomy, I'm not just looking at one cancer, I'm looking at multiple cancers. So I have one cancer that I try and identify as the index carcinoma, because that's the one that's either the highest grade or the highest stage, and it's usually the largest as well. That's the one that's actually going to drive that man's, path, going forward, because that's the one that's, probably the most biologically aggressive tumor. But he will have multiple different tumors usually in the background as well. So the problem with biopsy is sometimes you're not getting the actual MRI target. And so, we spend time at the multidisciplinary meetings trying to match those things up. So we'll often put up a picture of the MRI and a picture of where I've seen the biopsy targets come from, and say, okay, for this man, my biopsies don't seem like they're very high grade at all, but there looks like a high grade lesion on the MRI. Did we actually get it? So, in that sort of man, we might think about rebiopsying if we thought we might have missed it. So there are things we take into consideration. It's usually not just the biopsy standing alone. But yes, there is a proportion of biopsies that will be upgraded at radical prostatectomy. And that's because, we do think that there's a proportion that we're missing because of the multifocality and the heterogeneity of the disease. So, and And then the other thing is sometimes we'll only have one tiny focus on a biopsy, and then on the radical, you've got the whole tissue to look at. So, in those ones, there is actually a risk sometimes of even downgrading. So I might have a risk of high-grade disease in one core that I've seen that, and then in the radical, there's actually extra disease that's in the background, and we average it out and give you a global score. So it might be downgraded on the global. So yes. Concordance is about 65%, with a risk of some upgrading in the majority, and a little bit of downgrading in those ones that have been undersampled.
Now, how useful is staging of prostate cancer?
So early diagnosis improves prognosis and outcomes and actual cost to society and individuals. And governments don't invest in screening programs unless they're actually of benefit, globally to the country. And so, currently PSA testing is recommended in the right scenarios with discussion with GPs to support the men through making that decision. And so because of that, we know that the government wouldn't have invested if it wasn't actually of benefit to pick these things up quite early. Early diagnosis is life-saving, and most prostate cancer, as we've discussed, is quite slow growing. And so early detection actually leads to an excellent chance of survival. And more than 98% of men who are diagnosed at early stage are still alive at 5 years after diagnosis, compared to, 36% those that are quite late stage. So really treatment is determined by both the stage and the grade. So it's really important to identify the men that, will require extra treatment or different treatment pathways.
What are some of the poor prognostic indicators for prostate cancer?
So we had Gleason score, as I said, since the 60s, and it's been great. It's been this really powerful, prognostic indicator, and it's been fabulous. But in the last sort of decade or so, we've also identified other factors that we can see down the microscope that actually help us determine which men are more likely to behave in a more aggressive fashion. There are two things in particular that I really look for and have actually been recommended to include in our reports these days by the two societies for prostate urological pathology. And one of these is cribriform architecture, where you have the glands are actually more complex, and they have, it's almost, I almost think it's like looking down the bottom of a colander, when you're draining your pasta through your colander and you see your little holes. That's what it looks like. So I'm looking for that sort of colander pattern. That I kind of in my mind think of as pattern 4.5, because it is graded as a Gleason pattern 4, but it actually is a worse performer, and we know biologically and also molecularly it is worse. And the other one that sort of goes hand in hand with that, which I also think of as a grade 4.5, is intraductal carcinoma. So intraductal carcinoma originally was thought to be sort of like a precursor. We thought it was inside the ducts; it hadn't broken out into the gland yet. Well, yes, probably about 5% of the time we see intraductal carcinoma, it is a precursor, but we know most of the time now it's actually a growth pattern. So what happens is you have high-grade tumour somewhere in the gland that then goes back into the ducts and grows along the ducts. And it's a marker for higher grade disease. So if I see intraductal carcinoma just in the ducts in a man in his biopsies, yet I have no high-grade disease in the other biopsies, I really flag that, because I think probably this man's got some high-grade disease that we haven't actually hit with the biopsy needles, right? And so with that man, normally at the discussion at the MDT, we'll talk about him coming back relatively rapidly for another MRI and another rebiopsy, because we think he's got a very high risk of some high-grade disease that we haven't seen there. So those two things down the microscope I can tell, fairly well. And in fact, there was just a big consensus meeting in Boston in March amongst urological pathologists about how to really classify intraductal carcinoma better so that we're all on the same page, because that's quite important. We can also see some stage changes in the core biopsies. Sometimes we'll have sections of the seminal vesicle in the core biopsy, and that's a higher stage disease. So if that's involved, I'll report that. Or I can see if the tumour's actually gone outside the confines of the prostate gland as well. So that's also a higher grade disease. And then although more than 90% of prostate cancers are actually all the one type of disease, I keep saying to people I like doing prostate because it's very binary. It's like cancer, yes, no. Men are, when you look at women's histology, they have all these hormonal effects and it depends on what time they are in their cycle. And, it can look this way, that way, or any other way. Whereas men are quite easy to understand as cancer, yes, no, and they have the one type of cancer. I don't have to look at, 20 different types in my head and go, which one is it? Like more than 90% will have asana, well, actually more than 95% will have asana type cancer, which, is all one type, and I just go ahead and grade it. There is a small subset of other types of prostate cancer that men can get, and they will all behave worse. So there's a ductal type, which is also an adenocarcinoma, and we automatically give that a higher Gleason score. So that comes with an automatic high score. And then there are some types that we don't even give a score to that we know behave much worse. So we can have some of those with neuroendocrine features or small cell features, or sarcomatoid malignancies, which can also be adenocarcinomas of the prostate that have gone down that sarcomatoid pathway. So we don't grade them, but they behave really badly. And then just recently, in the last few years, there's been a lot of looking at what's happening in the background, right? So not just the glands themselves that are malignant. Often we know that when you actually have a tumor, it doesn't just impact the actual glands itself. It can actually impact the background and the environment. So we look now for the background stroma. And so that's not really come into the grading yet, but I think it is coming, that we will be needing to make an assessment of whether there's a reaction in the background stroma, what we call a desmoplastic reaction. But, I think this is a watch this space situation.
Does a perineural invasion or lymphovascular invasion have any sort of indication?
Yeah, that's interesting. So we don't even report perineural invasion in a radical prostatectomy specimen. So that's another difference from other cancers. Like in nearly every other cancer I would look at, I would report in an excision specimen perineural invasion. So in a radical, we see it so often. That's why we don't report it, because it probably doesn't actually add anything to that man's information. I think that's because when you think about where the gland usually has its cancer, most traditionally, what we talk about it as it being at the back on the lateral sides, and that's actually where the nerves sit anyway. So you tend to get a little bit of intraglandular perineural invasion because the nerves obviously go out of the gland, and perineural invasion can therefore be linked with extraprostatic extension. We do look like on the radical to actually see if we can see the extraprostatic extension. So we don't need to talk about the perineural because it's just a marker for potential extraprostatic extension. So we will have already seen it on the radical. On the core biopsies, it is different. We do report it on core biopsies, and that's because it's got if you've got if you've got perineural invasion, you've got about a 14% chance of having extraprostatic extension. So we do mention it, but it isn't reported on the radicals for those reasons. Lymphovascular invasion, yes, we do mention that as well. It doesn't necessarily correlate with actually having positive node status, though. So it's super rare. When we do see it, we do report on it, but it's super rare in the core biopsies. So, and the other problem is we can have this retraction artifact with the glands. And so often when I see consultation cases where people have called lymphovascular invasion, it's not, it's just retraction artifact. So, it is of value, but the value is less than the other things I discussed. Yeah.
Now, we're in the time of molecular markers and liquid biopsies. Are they of any use with prostate cancer for patients?
Yeah. So I think there's two scenarios we need to think about. One is early disease, when you're trying to work out whether this man is the man with the indolent cancer or not. The other one is advanced disease. So, we've actually got a man who's been treated for quite some time, and we're looking for actionable targets. So, he's actually got metastatic disease, and we're trying to find how we can actually give him a, more extended lifespan. So in the latter, with the more advanced disease, which is where we tend to use them more commonly, so I'll talk about that first. Yes, we're looking for things like androgen receptor, DNA repair genes, AKT, mTOR pathway changes, so the genes involved in cell cycle, BRCA. So BRCA2 in particular, but men with the BRCA status, whether it be germline or somatic, can be treated with PARP inhibitors. So, we want to think about those. We look at MSI, in regards to whether they're MSI high or not, and then they may be treated with checkpoint inhibitors. So we can do immunoperoxidase stains for that. And we can look for AKT inhibition, which we see with PTEN loss. And so that PTEN loss is actually one of the things we were discussing at the conference on intraductal carcinoma, because it tends to have PTEN loss. So there are particular chemotherapy agents that we can use in those scenarios with men with metastatic disease. In primary diagnosis and early on, when we're trying to work out whether it's, a man with a localized prostate cancer is more likely to have something we need to worry about. There are tissue-based multi-gene expression tools that we can use. The most common ones are Decipher and Oncotype DX and Polaris. And there's a protein-based one now as well, ProMark. And these might help to identify patients with localized disease who could potentially have worse outcomes. But it actually depends on quite good preservation of the tissue. And as I mentioned, there is this concept of heterogeneity of the disease. So you have to make sure you've got a biopsy that's actually reflecting, what could be their worst disease. Like if you're testing something that might not even be the bad actor, you may actually be falsely reassuring someone. And there's a significant cost for the patient associated with all of these tests, because none of them are government rebatable. And there's also been a lack of prospective validation in clinical trials. So, using a test that's not fully validated also comes with some sort of, caveats around it. So ASCO does not recommend routine use of these tests in the localized prostate cancer setting so far, but the National Comprehensive Cancer Network in the US just released new guidelines about testing in men, and I think over there it's actually overwhelmed part of their genetic testing because it's so common a cancer, and yet they suggest that you should do testing on these people for risk factor testing, and it's men who've got higher stage disease or mainly pattern 5 or lots of cause involved, but there are still quite a significant number of men in that bucket, right? So you can only test a certain number, so that puts you into a sort of a situation, do we test all these men? And in Australia that recommendation hasn't come through yet. That's an American recommendation, so yeah.
Now, you're using AI for prostate core biopsies, for image analysis and looking down the microscope, essentially. How is that going?
Yeah, it's going quite well. So I'm just in the beta testing phase right now, where I'm using the tool on quite a wide range of cases, the cases that just come through our door, to be able to start rolling this out within the laboratory, within a proper clinical setting. So I'm also involved with our college, the College of Pathologists in Australasia, where we're looking at advising on bringing AI into a lab. And, some AI products will have regulatory approval, and some will be in the process of obtaining it, and some won't have it yet. So we've got a guidance document actually up on the college website about how to bring in AI in a sort of safe way, the best way you could introduce it into the lab, all types of AI. And we're just in the process of working through recommendations for those different scenarios. One of those recommendations is when we haven't yet got TGA approval, and that's the situation that we're in right now. So that's why I'm doing a lot of testing, because that needs to be done at a lab level then before you roll it out. You can't just start using an AI in a lab without actually demonstrating that it doesn't actually impair your performance. So I'm at the process of doing two things essentially. One is doing the testing that needs to be done and documented, and then the other one is actually looking at the regulatory stuff right now, working with the college, and we've submitted for regulatory approval.
So are there any studies on AI and histology at the moment, or is that still coming?
Oh no, there's been a huge explosion. If you look on PubMed, the last 3 years, AI in pathology, especially in histopathology, has just exploded. So there's a lot of, studies, there's stuff coming out every week, all different algorithms looking at different things. There's quite a wide range of things. A lot of the stuff is looking at, what I've been doing, which is diagnostic work classifying. Our tool will classify and will grade and will actually pre-fill your report. So, it is quite a comprehensive tool. But there's actually a whole range of papers coming out on all different things. And so a lot of them are on classification or on grading, but some things are looking at being able to predict response to therapy or predict prognosis. One of the things, when I went into pathology, I didn't go into it thinking, oh, I can spend my life counting brown dots, which is what for a histopathologist that's actually become, part of your day, because a lot of the prognostic markers like your Ki-67 or your hormonal markers, ER, that sort of thing, you have to count proportions of dots or numbers or, and it's quite tedious. And those sorts of things, machines are actually much better at doing those sorts of things than humans are. They don't get distracted like I do, and they don't question their life choices like I do.
That's just called being a pathologist.
Yeah. The rest of it is good. And then things like scoring fish and immunohistochemistry and being able to even predict molecular alterations. So we're being asked to do a lot more with small bits of tissue now. So we might get a lung biopsy with a tiny bit of tissue and be asked to do, work out whether it's cancer, yes, no, work out what type of cancer it is, give it a grade, work out other factors, and then have enough tissue left over once you've done all your levels and your stains and everything to send it off for molecular testing. And then that molecular testing takes, a little while to come back as well. So it uses up tissue, takes time. And, AI these days, there's a number of papers out there where they've used it to actually predict the molecular outcome. So without even doing the molecular testing from the H&E, they've been able to identify, what the actual molecular findings will be. So there's a whole range of things. And now there's a sort of shift towards these foundation models, which is a different way of training, which should sort of upscale training and speed things up a lot. But one of the outcomes for that is that the product can have a sort of triage function because it's trained against multiple different tissue types. And so you can then say, okay, well, what do I want to prioritize in my lab? So it would also help with workflow in that situation, not just for diagnostic purposes. And there's this big talk now about a digital workflow and how that actually will change us from sort of being this very old specialty where everything's been exactly the same and everyone's done it the same way for like 100 years to being some sort of, more up-to-date kind of cutting edge, the whole thing, not just the diagnostic part.
Fiona, just very briefly, these AI tools you're using, are they basically doing the mundane and giving quick answers, or are these models developing such that they engage you in conversation and you can work towards some sort of outcome that way?
Yeah, so all of the AI models in pathology are as an adjunct. So none of them are to sort of replace the pathologist, which is also a concern that people actually ask me quite frequently. Is this going to take away our jobs? And, are you not going to be necessary anymore? And will the AI be more reliable? So for a start, it's to assist. The degree of assistance varies. So some models are very, very narrow and might just do a Ki-67, and that's it. And they're going to give you a number and then you can use that number. But there's not usually a conversational component. I have seen that in some radiology models. And when I've sort of had a look at that, it's sort of more at a junior level when people are sort of working through diagnostic possibilities. And I think it would be very useful for training. So they've actually used a large language model and adapted the large language model with a diagnostic model and are using them together. And there's actually a back and forth thing with the clinician. I haven't seen that in pathology yet. And I think realistically in your diagnostic day, that would be a little bit time consuming. Because I think, most of the time, so the other big difference with radiology is that they already are digitized, and actually having to digitize an image isn't an extra step. It's not extra cost. But for us, we have to get our already H&E image, then scan it, and then, run the AI model through it after you've done all of that extra scanning process. And that's actually costly. The scanners cost a lot of money. You've got to have people who can run them for you. They're not just standalone. And it's a time as well. There's extra time, in there to do that. So to go, in pathology to AI, it is an extra step to get that digitization in, and most labs are having to put out a big outlay to be able to do that. So you have to have reasons to offset that. Like, you wouldn't want to spend all this money digitizing things and then making your pathologist slower because they're having a bit of a chat about the diagnosis, right? So you've got to actually demonstrate that you're saving some time as well, for most labs to be able to make it worthwhile. A consideration, but maybe for training purposes more than actual day-to-day reporting.
Okay, so one day there might be one that takes Travis's seat here on this podcast. Fiona, just closing, do you have any final advice or thoughts about prostate cancer for doctors?
This is really a different type of tumour, from what we would classically think about how tumours kind of work. You get one tumour, it's pretty much very similar all throughout it at diagnosis, and you diagnose a tumour and you remove it or treat it. But prostate is really a heterogeneous disease with lots of different tumour deposits that may behave in different ways. And it's not the diagnosis that's so important, it's the risk, that we're assessing for this man. So we're actually saying, okay, now we've got cancer, what is the risk? And that's the key point, right? Like, when we work out the risk of progression is when we work out whether this man's actually going to need therapy right now or not. And that, it is a different tumour. So it's funny because we do the diagnosis based on architecture, which is not how we diagnose any other tumour. Like all the other tumours, it might be a small part to the grade, but it's not actually the grade. The grade is not based on architecture. And so from an AI perspective, that's why we went with the prostate first, because it's just the ideal thing for AI because it does do architecture really well. So, I think, the story that this is a bit of a different tumour. It's very, very common. We need to understand that we're risk analysing and predicting, and that therefore, having an adjunct to help us is also a really good thing because we want to actually be in the right risk category to treat the patient. So the AI is actually a good option in this situation.
Professor Fiona Maclean, thank you very much for being part of This Medical Life.
My pleasure.
Dr. Joanna Alford is a urologist and robotic surgeon who's completed her fellowship with the Royal Australasian College of Surgeons in Urology in 2019. Dr. Alford has experience in genitourinary reconstructive surgery, robotic uro-oncology, and open complex retroperitoneal surgery. She's also studied minimally invasive robotic uro-oncology in the UK. Dr. Joanna Alford works at the urology practice in Sydney and is our guest today on This Medical Life. Welcome, Joanna.
Thank you very much for having me.
Joanna, what are the determining factors for a patient to have a prostatectomy?
This is always a very difficult decision, and it's a very confusing decision-making area, both for clinicians, for patients, for their families. And the prevalence of prostate cancer means that this is a discussion we're having in the urology consultation offices every single day. I think the three main things that I usually talk to people about are the cancer behaviour, as in how likely is this cancer to cause you a problem? And there are a few different things that we look at to determine that. One is the percentage of the cancer that is a high-grade pattern. I think Fiona's probably talked a bit about this, the Gleason score, the more aggressive type of cancer on the biopsies. What their PSA behaviour is, so how quickly their PSA is rising over time. And do the biopsies line up with what we could or couldn't see on the MRI to kind of help with a visual representation of the tumour as well. And then apart from the cancer behaviour, it's very important to talk to the patient about their general health and their health preferences. So, we want to treat early localised prostate cancer essentially in fit and well patients who can see the benefits of the surgery long term. We lean towards kind of aggressive management in more aggressive cancers. The other consideration is, of course, life expectancy. So surgery only makes sense if someone's likely to live 10 years, and the guidelines kind of support that, although there are kind of, there's a lot of flexibility and ways to tailor the healthcare to the patient preferences.
Interesting. Are many patients surprised that they automatically think cancer means surgery? Is there sort of like saying, well, I have cancer, but I might not need surgery? Does that come up?
It does come up. And I think in the prostate cancer space, it comes up in two directions. The community education around that some prostate cancers we can watch over time is relatively good. And so I think that there are certainly a number of patients who come in already understanding the concept that there's a large proportion of prostate cancers where we can observe it rather than offer treatment. And I think I find myself more recently counselling people more often that this is actually a true cancer that we have to treat. This is not one of those prostate cancers that won't hurt you. And we're seeing about I think the message has been lost a little bit in the public health over the last 10 years that prostate cancer is something that kills young men in Australia. 2% of the patients under 50 are diagnosed, and it's in the top 10 cancer causes of premature death for men in Australia. So it is still a significant cancer. It's a very common cancer, and it's a cancer where there's a huge spectrum of clinical pathology, as in the tumours in different people behave very differently.
Are there any useful imaging studies that you do preoperatively?
This is one of the areas that's changed very dramatically in the last 10 years. So when I was training and kind of prior to 2014, 2016, if you had a PSA over 3, you were automatically referred for a transrectal biopsy of the prostate. Since then, the imaging modalities that have become available in Australia, and we're really world leaders in this respect, are MRI of the prostate. We also have PSMA PET scan, which is more validated for determining whether there's disease outside the prostate, so whether the cancer has spread. But we're world leaders in researching in that area. The team at St Vincent's in Sydney are doing amazing work in this regard. And so the imaging that we can use to diagnose and localize prostate cancer in the last 10 years has been absolutely revolutionary. And we're seeing much more specificity in the diagnosis. I think there's a lot of patients with a PSA around 3 who have a normal MRI who sometimes can avoid biopsy depending on their other clinical factors.
Now, you did mention biopsy. Is there any important histological diagnoses that you look for before operating?
In what way?
If there's perineural invasion or anything like that, is there anything that flags to you that, I need to operate on this?
Yeah, so the evidence about this is a bit confusing because there are some studies that say that Gleason 3+3 disease, which we would normally observe, that if there's perineural invasion, it's more likely to have spread outside the prostate capsule when you do prostatectomy. However, they're small studies. A lot of people find this controversial. So in our MDT, we're debating these kind of points very frequently. And this is one of the interesting and complex things about prostate cancer. Certainly, if you've got Gleason 7 disease, so 3+4, or a percentage of pattern 4, the bad actor, 4 or 5 are the bad actors in prostate cancer when you look under the microscope. And there are other factors with the pattern 4 or 5, such as perineural invasion. If you have a cribriform pattern, you automatically get assigned a 4. That's another kind of pathological feature. And lymphovascular invasion is the other one, where we kind of think this is when the cancers can behave in a way where they spread down the vessels or the nerves, then that predicts their ability to kind of cause a problem.
What are some of the common questions patients ask you when discussing prostate cancer and whether to go ahead or not?
Some of the common scenarios are, there's a lot of debate about which treatment to have, and patients want advice and counselling about what treatment modality they should choose. And in many respects, for younger patients, it's a little bit easier because if they have a localised cancer and they're thinking about radiation treatment or surgery and they definitely need treatment, they're not someone who we can watch, then it's a bit easier to say, look, you're young and you might be dealing with the side effects of radiation in 10 years that are going to affect your quality of life substantially or have secondary problems. And so for younger patients, the counselling towards radical prostatectomy or robotic surgery, if it's available, is a bit stronger. For patients who are 70, 75, or even very fit, up into 80, then the conversation about whether to offer radiation or surgery is a little bit more nuanced, and it's very patient preference dependent. Some people conceptually think, I would just rather die than have an operation in my pelvis. And this is a very strong feeling in some patients. Even some young patients say, there's no way I would accept surgery. I really want to have brachytherapy, or I really want to have radiation. So that's a frequent counselling kind of conversation. And I think from my point of view, the most important thing when you're having these conversations with patients is to try to understand their value concept, what they think is important in the healthcare, and then to tease that out so that you can provide them with appropriate information for them to make a decision.
I'm curious to know what the antipathy towards a pelvic operation is, because if I'm putting myself in those shoes, I want things dealt with.
Yes, well, some people have a strong preference for addressing the cancer, whatever the functional side effects might be of the treatment, right? They have a value system that is built around, I want the cancer treated. I'm focused on longevity and maximizing my chance of living 20 years. Other people say, that essentially the functional outcomes of many types of pelvic surgery are sexual dysfunction or voiding dysfunction, either bladder or bowel. And you can get some local discomfort. You can get urgency and frequency when you're passing urine because the bladder is irritated by whatever local treatment it is. That tends to be more with radiation treatment than surgery. And any surgery has a small complication rate of things not going as planned. And so, you have to prepare people for the full spectrum as best you can of experience that they might have. And some ideas really stick with people. So if you are 55 and very focused on your sexual function, then there's very small chance that you're going to accept surgery.
And now I understand that my question was based on having not had the benefit of counsel with you in the lead up to that decision.
That's very kind of you, but it is a very, very complicated area for patients to make decisions and to fully understand the ramifications of the decisions, both from a cancer and a functional point of view.
Do people want to know sort of percentages? What's the likelihood of sexual dysfunction or bladder complications? Do they want percentages, or do they say, how likely am I to get these kind of complications?
I mean, that's, again, a very individual thing. Some people would like a story or a picture, and some people want a number and they want to know where the number came from. And the numbers, depending on which country, which institution you look at, are quite variable. So I find that the counselling with numbers is a little bit more difficult as well, because generally the studies that are published are kind of based on data that it's at least 5 or 10 years old, and the technology is moving really fast. I'm personally not a strong numbers counsellor in my consultations because I find that patients find it a bit overwhelming. And if you're in a small percentage bracket, then it applies to you. So you don't feel like it. Generally, people don't feel reassured that you explain something serious is only a 2% chance, and it happens to them, in my experience.
Yeah. Now, one thing that happens in urology, particularly when I was studying, is the use of robotics. And it seems to be specifically for urology. I haven't actually seen it used in other areas. And I'm trying to work out, is there any advantages to this kind of surgery for robotics versus, traditional?
We're really at, in an interesting position in urology, and it's predominantly because of the position of the prostate. The prostate is like a little donut-shaped organ that sits on the bottom part of the bladder where the urine is trying to flow outside. The prostate is a little donut gland that's kind of sitting around the urine flow. It's tucked right down in the pelvis in this really tight, bony space with lots of nerves and veins around it. And so you've got the rectum or the back passage sitting just behind. Essentially, the distal pelvis is about 5 centimetres wide. 8 centimeters is a narrow pelvic inlet, but by the time you have the muscle and the tissue, it's about 5 centimeters working space, 8 centimeters. And if you think about the size of 2 hands, wrist, and the instruments that you can use if you only have a small space and you have to have your hands outside the pelvis, the robotic instruments give a full hand and wrist functionality with amazing fidelity for movement that is the size of your fingernail.
Wow.
So the precision operating, the ability with the gas insufflation to control venous bleeding, which is a fundamental risk with an open prostatectomy of massive venous bleeding. It's very difficult to control sometimes in an open operation. Just provides a huge advantage to the operator. Not to mention that the robotics gives you a 3D vision that's up much closer, and all of the medical students and trainees that we talk with, and I know this from my own experience learning on the robot, that you can see what people are doing so much better in a robotic surgery than an open surgery as a spectator, but also as the operator. You can zoom right in with the camera to kind of see the nerve fibers, see the muscle bundle, see if the tissue looks unusual and you think that there's tumor penetrating through into the capsule. From my point of view, I trained a lot in open surgery. I do a lot of open surgery, but the transformation to robotic in my practice has been absolutely unbelievable. Yep.
So when will you choose open versus over the robotic surgery then?
Sometimes it's about access, and sometimes it's about anatomy, sometimes it's about tumor behavior, and sometimes it's about resources. So the robotic scheduling, because it's such an expensive machine to have in the theatre complex, and it's obviously very marketable to patients, it's very popular, getting equitable access for surgeons to gain time to the robot is a little bit tricky. And the difference between the public and private system access to the robot in New South Wales, I don't know what it's like necessarily in every other state, but in New South Wales, it's a very contentious issue. Our public hospital doesn't have a robot at the moment, but there are some public and private arrangements for access to the robot to get that for public patients. So in terms of tumours, if it's a very complex tumour that appears that it would not be safely resectable with the robot, there aren't many, to be honest. When I was working in the UK, we did a huge volume of bladder work, and there was only one patient who we had to convert to open, and it's because he had a tumour that was too large to actually get the robot down alongside for the last part of the resection. There's very few things that the robot can't do at the moment.
In general terms, what's the recovery like following surgery?
This is another point where it's very contentious. I think the data is quite clear that there's a benefit in terms of in terms of length of stay in the hospital, in terms of blood loss intraoperatively for prostatectomy. And most of my patients who have radical prostatectomy are ready to go home the next day. Some people stay 2 or 3 days, whereas usually for an open prostatectomy, you're talking more like at best 3 to 5 days. The other thing is that I find that patients are recovering a little bit quicker from the surgery. And so at 2 weeks, they're kind of nearly back to normal activity, still a little bit tired up to 6 weeks, because obviously what's happened on the inside is a lot less than what's happened on the outside with the minimally invasive approach. But with the open surgery, I think that it generally takes people a little bit longer to get back on their feet and kind of be ready to go back to work. And they're more like 6 weeks to 3 months really feeling, back well again. And I made this point in a meeting during the week that, when a lot of our patients are aged 60 to 75, a lot of those people are still working and kind of toward the end of their career. The difference between 2 or 3 weeks off work and 6 or 8 weeks off work can be substantial at that time of your career. So I think from that point of view, it offers a huge benefit to patients that's measurable in the community but more difficult to measure in the hospital system.
We're going back to the histopathology report at the moment. So this is for a radical prostatectomy. Is there any features you are more interested than others when you look at a report from a radical prostatectomy?
Yeah, so the important things after prostatectomy, the two main things we consider aside from the recovery and functional outcomes, are what the PSA is doing at 6 weeks post-op and what the pathology shows from the histological specimen. So during the prostatectomy, we remove the prostate as one single specimen, ideally, and then it's sent to the lab, and lovely pathologists prepare the specimen, and they look to see how close the prostate is to the edge of the specimen, and what the final tumour grading was. And some of the things that can be significant if there's a persistent PSA post-operatively, so say your PSA is 0.3 at 6 weeks post-op, then we worry that either there's some micrometastatic burden outside the prostate that was not detected on the PSMA PET scan preoperatively, or there's some residual tumour at the site of the resection. And the pathological status of the specimen gives us another marker to say, was there any tumour left behind? Because if there's no tumour through to the edge of the specimen, then we take that to be a surrogate marker that it's been a complete excision.
Is there any important post-operative care you like for your patients?
I like them to be up and walking early and to get back to their kind of normal routine as soon as possible. I think that's protective from a DVT point of view, and I think it's good for their kind of spirit in recovery, that they get back to feeling bit more normal. We really emphasise in our practice strong pelvic floor physiotherapy, both preoperatively and postoperatively, and we have a good relationship with a very strong practice locally who provide amazing support to our patients. And patients say that makes a huge difference in their kind of early recovery of continence. Obviously, healthy diet and those type of things. But usually after the robotic procedure, people don't need a lot of pain relief when they go home. They have a bit of irritation with the urethral catheter, but usually we try and get that out at 7 days. There are some states and studies in the US where they're kind of doing a suprapubic catheter or a catheter through the tummy with no catheter in the urethra postoperatively. So, the postoperative management is advancing for sure.
Erectile dysfunction is a common known side effect. Is there any options for men who suffer from erectile dysfunction following a prostatectomy?
It is a common side effect, even with very good nerve sparing. I think the rough rate in the literature that we quote is that at 12 months, there's somewhere between 40 to 50% erections preserved, even with perfect nerve sparing. And so it's a very common post-operative consultation. Early in the post-operative recovery phase, we start what we call a penile rehabilitation program, where people start a low-dose tadalafil, 5 milligrams daily. That's like a Viagra equivalent, for those who are unfamiliar. And then we give a full dose twice a week of 20 milligrams. And we also, with the physiotherapists, encourage people to kind of resume sexual activity, local massage, and there are some vacuum devices that can help restore local blood flow. It's quite common that people lose penile length with a prostatectomy. And so this kind of early and supported rehabilitation program is really important. And we have a lot of specialist nurses in our practice who also can help, counsel people. And if people are having persistent erectile dysfunction, then generally we're quite quick to move them on to, say, intracavernosal injections or something else that can help to restore the confidence and restore the erectile function.
Joanna, are there any final thoughts or advice you have for doctors and even patients about prostatic surgery? And I'd like to include a reference to pelvic floor exercises, because you were saying pre and post-op, but I'm wondering whether you'd like all us blokes working on pelvic floor exercises anyway throughout life.
Yes, absolutely. I'm a huge proponent of pelvic floor physiotherapy, and I think that it can help anyone in the community who's having any difficulty with their urinary tract or thinks that they might be kind of going through prostate biopsies and going towards surgery. Start the prehabilitation as soon as you can. And the other thing that I would say, in relation to like the recent diagnosis of Joe Biden with advanced cancer, I think that the messaging around PSA testing has become very confusing in the community. But I think that the kind of routine screening is a really good idea, and that people should, feel confident to ask their GP for the screening if they have any family history, if they have any worries, or they have any new lower urinary tract symptoms, because it is a complicated area. So you can be your own advocate in that way.
Dr. Joanna Alford, thank you very much for being part of This Medical Life.
Thank you so much. Thank you for having me.
Dr. Carol Harris is a medical oncologist at St George and Sutherland Hospitals, senior lecturer at the University of New South Wales and a senior research fellow at the George Institute and the Australian and New Zealand Urogenital and Prostate Cancer Trials Group. Her clinical interests include genitourinary, breast cancer and survivorship, and the establishment and running of genitourinary clinical trials. Carol's our guest here on This Medical Life podcast. Carol, welcome.
Thank you.
What are the reasons you give chemotherapy to a patient with prostate cancer?
We give chemotherapy to patients with prostate cancer who have advanced disease or metastatic disease. That's cancer that has spread from the prostate to another part of the body. We sometimes give that when patients are first diagnosed, and sometimes we give that after people have been on a number of other treatments down the track, when other treatments have stopped working. I think it's probably important to say, though, that we don't ever use chemotherapy alone. What's really important in prostate cancer is that we also are suppressing the hormones. So all our patients are also on androgen deprivation therapy, which is a medication that it's an injection that starves the cancer of hormone treatment that might make the cancer grow. And sometimes there's tablets as well. So chemotherapy is given to some patients with prostate cancer, but not everyone. But everyone gets the hormone blocking treatment.
So what are the important features in considering if someone needs chemotherapy or not? Now, you mentioned initially metastatic disease. Is there other times that they will receive it that they don't have metastatic disease?
Not at the moment. So in some cancers, we use chemotherapy as sort of an adjuvant setting. So you might cut out a cancer. So say in breast cancer or bowel cancer, you'll cut out a cancer and then you'll give chemotherapy. In prostate cancer, chemotherapy is not used in that stage. Chemotherapy is used only in the advanced stage. And even then, we're quite picky about who we use. So patients who are newly diagnosed with prostate cancer, whose cancer have to have nasty enough cancer. So I know that sounds strange, but we look at things like the grade of the cancer, and I think you've talked about that before. So if it's a higher grade and if it's spread to lots of places in the body, particularly if it's spread beyond the bones and the lymph nodes to what we call visceral disease, so liver or lung. So people who've got high volume and high risk disease when they're first diagnosed, they're the patients we give chemotherapy to. And as I said, otherwise, we'll actually try and avoid chemotherapy if we can in the first instance and give just the hormone injections and tablets. And otherwise, it's later on down the track after other treatments. But we don't actually use it in the adjuvant setting in early like we do in some other cancers.
So with things like breast cancer, we have targeted therapies that are going. Do we have targeted therapies for prostate cancer?
Yes, we do. So there's a couple that are perhaps worth talking about. And obviously, like every cancer, there's a whole lot more that are in development. So one of the ones that I'll probably talk about three main ones and then a comment at the end about exercise, because I consider that a targeted treatment. But we have androgen receptor pathway inhibitors as the first thing. So these are tablets that are given to patients that block the testosterone or the androgen pathway, and a bit similar to breast cancer, these are treatments that starve the cancer cell and stop them growing. And these are now being used broadly. So we always use them down the track when people had advanced disease. Now when people are newly diagnosed, and watch this space, they're going to be moving a little bit earlier over the coming years. So this is one of the first things. So it's like a targeted hormone blocking treatment, if you like. And there's a couple of different ways these work and a number of treatments in this space. So that's the first sort of targeted treatment we use. The second one is PARP inhibitors. And again, it's a similar sort of thing that we use in breast cancer. So a PARP inhibitor is, it exploits the difference between cancer cells and normal cells. Cancer cells often grow uncontrollably, and the PARP inhibitors block that protein that helps the cancer cell repair their damaged DNA. And so by blocking this, it's harder for cancer cells to fix themselves, and so they die. And so these PARP inhibitors we've been using predominantly in people who have a mutation of a gene that might make the cancer grow like this. And that can either be a gene that you inherited from a parent and pass on, or a gene that goes wrong in the cancer itself. And these are quite exciting. Again, there's more of this happening and there's going to be more studies in this space, but this is certainly a treatment that is quite exciting. And then the third one, just to mention, is a treatment called lutetium, which is very topical at the moment for all sorts of reasons, one of the reasons being getting access to it. And it's a treatment where you inject a radio-labeled ligand. So basically, it tracks out the PSA avid, so the prostate cancer in the body, and delivers a local radiation treatment to that area. So it kills the cancer cells, but spares the healthy tissues. So this is really quite an exciting area as well. That is, well, we're very excited about it. The problem with this drug is access to it in Australia at the moment, and the cost of it. It's very expensive. But that's probably they're the three targeted treatments, if you like, that are available at the moment and are being used quite a lot. There's a number of clinical trials with newer treatments. And as I said, I was going to have a quick mention about exercise, because I think exercise is really important as a targeted treatment as well, not only for side effects, but as an anti-cancer therapy, and all our patients should be exercising.
I am really heartened to hear that, because I don't think the fitness industry or the gym sector makes enough about that. They talk about doing it for cardiovascular and maybe a little bit of mental health, but I don't think this is known or understood, that there is a correlation there, that it could also be good for your prostate health.
Only in the last month, and I'm going off topic, but there was a study published in the New England Journal of Exercise and Colon Cancer. So we as oncologists know about it. There's no fund. It's not funded. So all these new fancy drugs get funded, but exercise doesn't. But I think if we keep talking about it, maybe more people will know about it, because it's really important.
Now, we've mentioned chemotherapy and targeted agents. What are some of the common side effects for these treatments?
The chemotherapy we give in prostate cancer isn't as nasty as some of the chemotherapies given in other cancers. So sometimes you combine 1, 2, or 3 or 4 treatments. In prostate cancer, we give one at a time. And when you think about it, most of our men are older, 70, 80 often. So it is the standard chemotherapy side effects, but it's not too bad compared to some of the others. So you can get fatigue, you can get risk of infection. We always say you can get nausea, but I don't find that too much. Perhaps one of the ones to be aware of is you can get peripheral neuropathy, so numbness or tingling in the fingers and hands, and that can we try and monitor that so it doesn't interfere with the patient's quality of life, and that's certainly probably one of the things we do watch closely. In terms of some of those other treatments I talked about, the hormone blocking treatment, I kind of nickname it the male menopause. So it's all those symptoms of that women have known about, feeling tired, so not as much muscle strength, hot flushes, sometimes some brain fog, effect on bone health. So those sorts of things do happen with all the hormone blocking therapy. Lutetium, if we ever sort out how to get this in Australia properly, really well tolerated, rare risk of hematological problems, but otherwise quite well tolerated. And the PARP inhibitors have relatively, can have a bit of GI upset, a bit of nausea, but can affect the hematological, like the blood counts. But a lot of these treatments, very well. The patients are often monitored closely by their oncologist. So I'd say none of them are horrendous.
Do any of these fit into immunotherapy?
No. So immunotherapy is another thing again. So look, unfortunately in prostate cancer, immunotherapy hasn't been the great hope that it has been in many other cancers. I mean, it's revolutionised melanoma and certain others. There is a very small subset in prostate cancer that benefit from immunotherapy. You have to do testing on the tumour to see if you've got a certain we call microsite instability or MSI high tumour burden. So certain tests on the genomic testing, so genes on the actual cancer. But it's a very small proportion of people who actually respond to immunotherapy. We do check for it, and of course it's not funded in Australia for this type of people. It's, in all honesty, it's probably still in clinical trials or when you've gone through the mainstay of treatments. I've not seen much personal success from it. And maybe we can further identify those that will benefit. But unfortunately, in prostate cancer, immunotherapy is not as good as in many other cancers.
What determines the cycle and duration of therapy for treatment for patients?
Firstly, the simple answer to that is clinical trials. So everything's based on evidence-based medicine and what's been done. When someone's newly diagnosed and you use chemotherapy up front, there's set protocols. So often it's only 6 cycles of chemo, like a hard bang to try and knock the cancer down and then manage it with hormone therapy. When people have had other cycles of treatment and they're a bit further down the track, we give a little bit longer chemotherapy, but that's when it's a little bit more negotiable. So if a patient's tolerating it and it's working and they want to keep going, we'll keep it going. But often things like that peripheral neuropathy or other side effects, people are like, I've had enough, or the doctor or the patient together will talk and go, yeah, that's enough. Let's leave it there. We use things like we monitor the PSA, we do imaging, we monitor patient side effects. So all of that comes into play when we're trying to decide the length of time on treatment and what the patients will benefit from. Lutetium has its own schedule of between 2 to 6 cycles. PARP inhibitor has its own schedule. And it's really, really interesting at the moment in things like the hormone blocking treatment. We used to just always do a set and forget. You're on the hormone therapy and there you are, you will stay on it forever. But now we're looking at, should we give people breaks of treatment? Should people have de-escalation? Should have a period of time and then a break if it's working and then back on it and a break? That is currently being explored in studies, how long people should be on it. But traditionally, people have been on the hormone blocking therapy for a long time and short cycles of things like chemotherapy in between.
The hormone therapy just catches me a little bit. Does that mean that there are side effects such as erectile dysfunction when you're on hormone therapy and everything like that?
Yeah, look, that can be part of the problem as well. Probably not discussed enough, but yes, that can be part of the issue, particularly with the injections. And it's an issue for many patients. And of course, many patients don't want to bring it up and doctors are busy and this is not an excuse, but I do think it's something that could be better managed.
So it is manageable if you're having chemotherapy treatment, or is it just a known side effect that this is going to happen?
It's not so much with the chemotherapy, it's with the androgen deprivation therapy or the hormone blocking treatment. It doesn't, like some people are fine, so some people don't have it, but like with all these things, some people can be affected more significantly than others. And I have had patients, so we try and link people in, and often actually our urologists and urologist nurses are helpful in that co-management of situations like that, and there are some specialised nurses and clinics as well. But there are the times when that could be the reason why patients don't want to stay on treatment, and it's all part of the discussion. So all the time it's the side effects, and I think you've hit on a really important point here. I mean, I've talked about what I think is important, so I'm watching the bloods and I'm watching the neuropathy and whatever, but what's important to the patient could be completely different. So we've got to remember to ask those questions. So I actually appreciate you bringing that up.
I mean, I would be saying keeping alive would be the top of my list.
Well, it's interesting. It really depends. So I'd have this discussion with patients about aggressiveness of treatment versus quality of life. And I think that's how I would behave too. But for some people, that balance is more important. So it's really important to keep having those discussions. Yeah.
How do you measure treatment goals and patient progress through this?
I think I briefly touched on it. The PSA, which is the blood test for prostate cancer, is probably the easiest way to keep an eye on the true medical progress. So we do regular PSA blood tests when patients are on treatment, and we like to see that fall. And the lower it gets, the better. I no longer try and give people a magic number, because for some people that will fall to completely undetectable, and for others it will just fall to a lower level. So a blood test done regularly on treatment is certainly one of the easiest ways. We do imaging as well, and certainly if that PSA starts creeping up, or often we just sort of do them with some degree of regularity at certain intervals. And that has sort of moved in Australia. We kind of have led the way a bit. Often in Australia, people doing PSMA PET scans, although in other parts of the world, CT and bone scans, and that is an entire podcast as to which is better. So we're not going to go into that today. So there's that. And I think, so that's how we tell sort of medically what's going on. But as we've sort of talked about as well, it's really important how the patient is tolerating treatment. So side effects as well, and watching for all of those things. And I mean, I had a patient recently who was on my treatment, and the PSA dropped from in the thousands to in single digits, but he was falling over and having, his quality of life is affected to the point that it wasn't, we had to make a decision and we cut back on his therapy. So there's those issues as well.
This is relevant to other cancers, and I don't know if it's relevant for prostate cancer. Liquid biopsies, where you're actually looking at like the genetics and the actual mutations in cancer, is that relevant in prostate cancer?
Yeah, so what we try and do for almost all our patients with prostate cancer is biopsies. We're not using liquid biopsies so much. We're using tissue biopsies. So again, I don't tend to see the patients in early prostate cancer, so those that are curable. I only see the patients with advanced disease. So that's the time that we do it. So for pretty much any of our patients we try and send off a sample of the tumour and have genomic testing done in the tumour. So I'm sure you understand what that is, but that's where what genes have gone wrong in that cancer to make the cancer grow. So sometimes it helps us with prognostication. It can say there's a nasty gene here and this cancer is going to be hard to treat. And sometimes it says there's a gene here, like the BRCA gene, where things like the PARP inhibitors might work, so we can target treatments. And sometimes there's genes there that there may be a clinical trial somewhere in Australia where we could match a patient to a new and exciting treatment. So we do genomic testings, and we're fortunate in Australia at the moment to have the Omico testing system where it's free for patients. It's just not an immediate response. It does take a couple of months to get that result, or patients can pay privately to have that done. So I try and do that on all of my patients. And I think that's important. And it's not so much watching the progress of the disease. And the liquid biopsy is sort of, again, in research mode, I'd say, in prostate cancer. But the testing of the tissue for all the genes, I am trying to do almost universally where I can. And whilst it's free through that program, it's easy. But when I'm telling a patient they have to pay a few $1,000s for it, it's a harder discussion sometimes for some of our patients.
What are some of the common questions you get asked from patients?
I think the commonest one is, why did I get this? And that's across any cancer. And I normally can't answer that. There's a small proportion of patients who have got a genetic link, though they've inherited from their parents, but almost all the patients can't. I mean, prostate cancer is very common, and being male and getting older are probably two of the main reasons for getting prostate cancer. That's probably the most common question I've got. I also get the questions about, what else can I do? So, I mean, sometimes we come in with that very medicalized approach of, have this injection, have this infusion, whatever. And so patients are always looking for extra things. And that's certainly when I do push the exercise and really recommend that. They're also often asking about complementary medicines, and I often say I'm not an expert in that, but I give them some resources and what have you. And I think otherwise it's sometimes it's the how long have I got, or the questions about treatment itself. So they're probably some of the other questions that I get.
Now, looking at the stages, 5-year survival rates, what are they like from 1 to 4?
Ahead of this podcast, just looked up the Australian stats for prostate cancer in Australia, and across the board, the survival rate is, so we talk about 5-year survival. So across the board, it's about 96% for all comers for prostate cancer. Now, keep in mind, a lot of patients are diagnosed very early, and that's certainly improved from about 70% back in the 90s. So that's very exciting. If patients are diagnosed with prostate cancer that is contained within the prostate, they have an excellent survival rate, or 5-year survival, and getting close to 95 to 100%, which is great. It drops once you get to higher stages, so stage 3, once you're starting breaking out of the prostate to nearby structures. That can be more like the sort of low 90s or high 80s. And I think stage 4 cancer, where I see patients, the 5-year survival rate is about 36%. But I can tell you, over the years I've been treating prostate cancer, the survival is getting longer, and we are doing better for our patients. So we have some patients who live many years with prostate cancer. So it all depends on when you're diagnosed. So everything in cancer, try and catch it early. And if it's advanced, it's not quite as good news.
Is there any signs during treatment that are good or bad prognostic signs?
So I think, again, if we watch that PSA, so if someone has high volume disease, the PSA can go up before the PSA goes down, and that's okay. So watching the PSA is really important. Doing regular scanning to see how things are going, I think is important. And I think some of the sort of red flags I particularly watch out for is someone who's got new bone pain or weight loss, or some of those systemic signs that sort of say, hey, something's going on, as obviously in line with the PSA and the blood, the imaging, because occasionally there are a small group of patients where the PSA never goes up. And so you've got to look at those clinical symptoms and imaging as well. And I use what I call the end of the bedogram, which is what a patient looks like when you're looking at them. There's, it's like if they can't walk from the clinic room from the waiting room to your clinic room, something's going on.
Wow. Carol, you threw one at us from left of field by mentioning the fitness aspect, and it triggered a distant memory. When I was in radio in the early 90s, I used to regularly interview the people from New Scientist, and I do recall, and this is left field, them saying that there was research showing that if gentlemen kept their parts sexually active, it regularly for life, it really does help guard against prostate cancer. Do you have anything that connects with that at all? I know this is a random one to throw at you, but it's just this snagging memory from the 90s, a New Scientist magazine.
Look, I seem to have a memory of some comments like that as well. I must admit, I can't give you a scientific answer other than that sounds valid. So thank you for throwing that one at me. Often those sorts of things, I turf to the urologist. That's a bit rude. It sounds valid.
All right. And then finally, back into the more conventional channeling of questions. Have you got any final thoughts, final advice for doctors or patients even about oncology in prostate cancer?
The single most important thing in oncology is communication. It's talking to your patients and patients talking to us and all of us talking to each other, because as you mentioned the erectile dysfunction, that's often not brought up, but it's just if a patient, that's really important. I love patients who've done their research and come in with a list. I think that's fabulous. I'd rather have an informed discussion. I think the other thing to say is times are changing. What I'm saying now, this is all going to change in 5 years. So you might have to have another podcast then when the completely landscape changes again. And probably the last comment is just to talk to your doctor about if there's any clinical trials or anything new on the horizon.
So the survival rate for the validity of this content in 5 years is probably about 50%, I imagine.
Let's go for that, yeah.
Dr. Carol Harris, thank you very much for being part of This Medical Life.
No, thank you so much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.